Well, it is a pleasure to see so many familiar faces, and thank you for having us here today. My name is Dr. Glatts, and I'm here with Charlene Wu. Together we're representing the ENDD team, and we'll be discussing the behavioral landscape of Syngap, talking about some insights from some standardized behavioral assessments. So here's a brief overview of what we'll go through today. We'll start by kind of conceptualizing what difficult behavior is, talk about some tools for assessing behavior. We'll focus mainly on two of them today, the CBCL or Child Behavior Checklist, as well as the Vineland Adaptive Behavioral Scale, Vineland for short. We'll talk about some of the data from our own clinic, and then just discuss briefly some next steps. So what is difficult behavior? I want to start by defining this maybe seemingly self-explanatory concept. Difficult behavior, as I think of it, is observable, outwardly directed behavior like severe tantrums, aggression, self-injury, or extreme non-compliance that is happening with a frequency that is more intense or more frequent than the child's developmental level, and it needs to interfere with functioning, so participation in the home, the school, the community.
So when we talk about challenging behaviors, it can include one to all of the following. So it can include high emotional reactivity, frequent irritability, tantrums and meltdowns, aggressive outbursts, self-injury, impulsivity and hyperactivity, low frustration tolerance, difficulty with transitions, and then finally sensory-driven dysregulation that results in outward behaviors.
So there really isn't one best scale to look at behavior. That's because behavior is dynamic. It is multidimensional, and we expect it to change with age, right? A tantrum in a 2-year-old, normal. A tantrum in a 12-year-old, probably not as normal. Behavior can and does vary across settings and by different observers. We expect that it will change to some degree. And behavioral constructs are not discrete biological categories. They're rather attempts to summarize a pattern. So no one tool is adequate because no tool can really capture the complexity, the heterogeneity, and the changeability of behavior, especially in children with neurodevelopmental disorders. So you can see here just a smattering of some tools to assess behavior. This is not an exhaustive list. And like I mentioned, we're going to focus on two of them today. So the Child Behavior Checklist is a standardized parent reporting tool that looks at emotional, social, and behavioral functioning. There are two versions based on age, so a younger cohort, about 1.5 to 5 years, and then a school-aged cohort, 6 to 18 years. It's typically completed by parents and caregivers and has anywhere between 99 and 113 questions. You can see here an example of what those questions look like. So they're scored on a range of 0, 1 to 2, never, sometimes, always. The CBCL gives you a report out of syndrome scales. Think things like sleep problems, attention problems, emotional dysregulation, things like that. It then maps those syndrome scales onto DSM-5 oriented scales, so clinical diagnoses of things like ADHD, autism, somatic complaints, anxiety, depression, things like that. And it also maps them onto 3 broadband scales, so looking at total problems, kind of the overall number of problems or symptom burden, externalizing problems, so those outwardly directed behaviors, as well as internalizing problems, or those kind of things that we keep inside, anxiety thoughts. When we looked at data from Simon's Searchlight, so we looked at data that captures children with multiple different neurodevelopmental disorders, including children with Syngap, we found that there is really an elevated behavioral and emotional symptom component compared to the broader group. So if we're looking at individuals with Syngap compared to other individuals with neurodevelopmental disorders, they do report more behavioral and emotional challenges. They are reporting the most challenges with attention, thought problems, and social problems. And we saw that oppositionality, acting out, and aggression seemed to really appear between ages 5 and 12. That's not to say that it disappears after age 12, but that's when we really see it start to pop up in the data. And I should note the CBCL, again, only goes until age 18.
The second assessment we'll kind of briefly go over is the Vineland Adaptive Behavior Scale, which I'm sure a lot of you are already pretty familiar with. They're very frequently filled out in schools. But basically the Vineland can be used with kids from birth to, I guess I shouldn't say kids, grown-ups, over the age of 90. It is typically completed by a parent and or the caregiver, and it is over multiple domains. So there's a communication domain, daily living skills, and a socialization domain. The three of those together will come up with the adaptive behavior composite score. There is a motor skills and a maladaptive behavior subtest, but those are optional and don't have to be completed. And again, this information that we're giving today is also off of the Simon Searchlight data, so it is in comparison to other children with neurodevelopmental disorders, including our kids with SYNGAP. Our kids with SYNGAP did demonstrate lower scores across the scales as compared to the broader neurodevelopmental disorders group. There's also a faster decline in scores across all of the ages. And then there is a floor effect that limits our ability to detect true differences towards the later years. And the reason for that is really because our kids the distance between where they are and where they should be grows bigger and bigger as they age. And so it's harder to capture those differences with something like the Vineland.
Careful. So then we wanted to look at the individuals who came through our ENDD clinic. We did a retrospective chart review looking at the charts of 100 Syngapians. 87% scored within the autism range on the CARS, the Childhood Autism Rating Scale, so that's not diagnostic, but 77% do have or carry an autism diagnosis. Of those, about 59% were reporting challenging behaviors, 36% were receiving ABA, and 29% reported taking medications for behaviors. So we then went on to kind of map this onto a behavioral scale, looking at those challenging, outwardly directed behaviors. For individuals who reported none, they got a 0. If they reported mild behaviors, biting, scratching, didn't have any medication requirements, they received a 1. A score of 2, think more outwardly directed aggression at others, it's more purposeful, maybe requiring medication management with something like an SSRI or a stimulant. And a 3 reflects severe behaviors, severe conduct or safety concerns, possibly requiring medication management with an atypical antipsychotic, things like that. Myself and one of our other OTs, Kristen Cunningham, both looked at our data. So these are the histories that I'm taking. These are the histories that OT is taking from the parents and caregivers who come through our clinic. And we noticed that we had good inter-rater reliability, meaning what families were telling me, they were also telling her. So some takeaways from this data, we didn't find a statistically significant linear relationship between age and severity score. So we weren't necessarily seeing that as you get older, behaviors are more intense. We did see, though, that severity really started to increase around age 5, and we saw a peak around age 12 and a half. Now, again, we were talking about this earlier. That is not to say that behavior gets better after age 12 and a half. We didn't see it come down or get better. We just didn't see it getting worse. But that also can reflect the fact that our scale ends at 3, and the fact that we don't have as many adolescent Syngapians that have come through our clinic. And there's also a potential bias because we can only report data on those individuals who do come to our clinic, right? So we are missing a large, potentially, population of individuals who can't make it into clinic because of behavior. So we would have to do additional work to look at this scale and to validate it further.
Perfect. I also will say that everyone probably in this room knows that any negative behavior that is exhibited by anybody, whether it is a Syngapian or another person, those behaviors will impact their ability to engage with life, right? So that life could include their self-care, their school activities, their play activities, their ability to build social relationships with their peers and with other people in their lives. And it could be, again, a combination of any of the negative behaviors that you are noticing. So self-injury, the high emotional reactivity, the low frustration tolerance, all of these things combined can impact an individual's ability to engage with their self-care, as well as engage with their ability to learn and grow sort of as they progress through life. As occupational therapists, the way that we address both the challenge of allowing kids to grow and to learn as they can, while at the same time managing their behaviors, is to utilize what we call a just right challenge. The metaphor we always like to use is think about Goldilocks and the three bears, right? The Goldilocks only liked the porridge that was just right. There was some porridge that was too hot, some porridge that was too cold. So our jobs as therapists is to figure out what that just right porridge is. The goal of the Just Right Challenge is we want the child to find success, but we also want to be able to set them up for success. So we're not giving them a task without providing them the support that they need in order to achieve that success. We also want to decrease the propensity for challenging behaviors in the midst of doing a task or working on an activity or learning a new skill. The challenge portion of the Just Right Challenge is that we want to set the correct expectation. We don't want things to be too easy so that the child doesn't have to feel challenged and they just kind of do as they do and roll along so they're not learning or growing. But we also want to provide them with enough support to achieve something that might be just too difficult for them. And the last thing is we really truly want to hold them accountable. If we're asking them to do something and providing them with enough support to do it, we want to make sure that they are able to meet that particular goal. It is going to be a little bit of a challenge in order to figure out what that balance is going to be, but in an effort to try to minimize their behaviors as well as help them to grow, we need to challenge them just a little bit. Having said all of that, sometimes we don't want to challenge too much because we're afraid of eliciting a behavior, we're afraid of eliciting something, and so sometimes even as therapists we shy away from providing them with that challenge. So saying that is to say that wanting to be safe, ensuring your safety as well as the safety of your child is an appropriate response in this situation, right? We don't ever want anybody to feel like they can't protect themselves and protect their child when they are having these sort of elicited or these spontaneous behaviors. There are various safe methods of de-escalation that involve safe handling and safe holds to maintain safety for everybody involved. And there is no, as of right now, there isn't any research out there to indicate what is better than others. However, there is research being conducted in terms of how best to manage behaviors in sort of our higher support needs autistic community as well as in the intellectual disability community. So there is definitely stuff out there. We just haven't looked through any of those things right now. And then lastly, we just want to thank everybody at CHOPS ENDD because obviously we wouldn't have this opportunity to present without them, and also for you guys. It was lovely to see so many familiar faces outside of the clinic setting. So thank you guys for your participation and your support. So.